Great. Welcome back. I hope you had a nice lunch. You'll see we have the computer set up for you for the exercises this afternoon. Before that, I'm going to present a little bit of our work on inter and intrastate variation in Medicaid expenditures. This was a nice project we did using the MAX data to look to see how utilization and cost varied across states, and how that variation compared to the Medicare program. So as we talked this morning, the Medicaid program is this joint state and federal program where the federal government sets a lot of the ground rules and minimums on eligibility and covered services. The states have a lot of discretion in setting the actual eligibility thresholds and choosing which services are covered, and also in setting provider payment rates. So all of that could affect utilization and cost. So there's been a pretty substantial literature around area variations in the Medicare program, but much less in Medicaid. Anyone know why they were kind of most of it is focused on Medicare? Well, it covers more. So it's a national program. It covers, it's pretty, similar coverage. Right. Well, that's an advantage. But so why did all these researchers focus on Medicare and just on Medicare?
It's the first pair.
It's the first pair. But why are you here today to focus on Medicaid? The data. So the data was available. So they had a data set on the whole country. And then they could use that to look at how care variation varied across the country. And that wasn't available for the Medicaid program, right? We would have to go kind of to state to pull that together. And so, so we said, well, wow, now we have, most of the country, and let's see what we can do and see if the story holds up. But there are reasons to think there might be more variation in the Medicaid program, specifically kind of the ability of states to set some of these thresholds. So we decided to ask these research questions. So we wanted to look at area variation, and we wanted to look at why. What is driving variation in the Medicaid program? Is it price or is it volume? So on the Medicare side, it's largely a story about volume, and largely a story about inpatient admissions. There isn't a lot of price variation in Medicare. There are some geographic price adjustments, but that's about the most of it. The Medicaid, however, there's a lot of discretion on setting payment rates. So we wanted to see, does price play a role in variation expenditures? And then we're also interested in whether or not Medicaid variation was greater or less than Medicare, and was it related to Medicare, right? So were places that were high in Medicare spending also high in Medicaid spending? And then we wanted to see if we could answer the question, is more or better? So a lot in the area variations literature, at least in Medicare, there seems to be a little bit of a consensus that more is not necessarily better, and in fact it might be worse, that some areas might have rates of overtreatment. So they've shown kind of increases in mortality in places that have really high utilization. But in Medicaid, we thought, well, maybe it might be a little bit different because people are kind of worried more about access to care and things like that in Medicaid. And so perhaps we might find in Medicaid more is better. So that was kind of some of the things we wanted to answer. And we don't answer that thoroughly, that third question, but we do kind of, I think, have a little bit of a window in on it. We had a few more years of data at this point. We 2001 through 2005 for 50 states and DC. And just a little bit of a background that how MAX is developed. And so we had about 280 million beneficiaries at the start of the study. And that's counting people multiple times, when they're in multiple years. But we had a lot of data. So then we started, making some restrictions. We excluded people with restricted benefits, and And we decided to focus on what we began to call the CAMODS. So these are cash assistance, Medicaid only, fee-for-service beneficiaries with disabilities. So how many restrictions are that? So we're looking at the disabled. So we're looking at the disabled aid categories. And they include 12 and a few other categories. Among those, we're looking at just those receiving cash assistance. So the thought here was there's more uniform standards for receipt of cash assistance. And so we focused on just the eligibility codes that indicated they receive kind of a monthly monetary payment from Social Security due to their disability. So we're not including people that are in there just because they're because they're disabled and low income. They actually have to receive disability payments. And then we restricted to Medicaid only, so we eliminated the dual eligibles because a lot of their care would be covered by the Medicare program, and we wouldn't get a full picture of utilization and cost for them. And then we also limited it to those with fee-for-service data because we thought we'd have incomplete data in managed care. So we're focusing on CAMOD. So it's a subset of the disabled beneficiaries. And then we excluded these states because the penetration of managed care was so high that we thought that whomever is left would look different enough from the rest of the state that it wouldn't be representative. It could be. So it could be in the first 2 years of their disability, or people that are not going to qualify for Medicare, which can happen. And this gives you an idea of the beneficiaries we're looking at. So the CAMODS are in the dark purple on the top, and the below that are the rest of the disabled. So you can see we're looking at about a little more than half of the disabled are the group we're focusing on. So we're focusing on the deep purple. And then the green are aged, the red are adults, and the blue are children. And so the first column is all beneficiaries there. So we're looking at about 10% of beneficiaries, but they end up accounting for a little bit over 20% of total expenditures, and about 25% of acute care expenditures. So they do account for a good chunk of Medicaid spending. And so we're focusing then on acute care spending. You can see the long-term care spending is dominated by the aged and the dually eligible disabled. And these are correlation coefficients. So these are kind of standardized expenditures per beneficiary. So that's the top one. So that's basically looking at per person expenditures standardized to the same distribution of enrollees in aid categories across states. So accounting for the fact that some states might have a greater proportion of people that are TANF children, for example. So so we kind of looked at overall expenditures, expenditures per CAMOD, and then acute and long-term care expenditures per CAMOD. So the third one down, the 0.81, so we're looking at acute expenditures among CAMODs. So the 0.81 is the correlation it has with overall total expenditures. So even though we're focusing on this more specific group, our argument is it's very strongly related to state-level spending. So 0.81 is a pretty high correlation coefficient. So that was kind of our justification. And then this talks about how we measure price and volume. So how do you measure price and volume in claims? Well, for inpatient, it's pretty straightforward. Volume is the number of inpatient days, and price is the expenditure per day. So the average expenditure for an inpatient day. So that's our measure of price and volume. Certainly, some, all inpatient days aren't the same. A day spent in the ICU is more important, more costly than a day on the general floor. But we, picked an inpatient day. On outpatient, it was a little trickier because there's a lot of more heterogeneity in what's happening in outpatient care. but we went with the same idea of number of days or visits and the expenditure per day when there was a visit, so price and volume. And then pharmacy was a little more tricky yet in that you could do the number of fills, and we had that as a volume measure. But also, there's, again, a lot of variation in what medication you're filling. So an antibiotic has a lot different cost than, say, an antipsychotic. And so we put it in a separate volume measure that was supposed to get at the difference in the types of medications, and then a price measure that was actually for each medication type, do they spend more than other states? In the results I'll show you, we call that second volume the mix. So it's the mix of medications. Are they using more or expensive versus less expensive medications, and the prices, how much they're paying for it. So we kind of go through these, develop these algorithms to count these things and to separate price and volume, and then we calculate incremental effects. So we want to decompose the price and volume effects. So with the incremental volume effect is a difference between the actual and the mean value, so the volume. So VI is a volume in state I, where VM is the mean volume across states. And so this would be the difference in that state from the mean multiplied by the mean price would give you that incremental volume effect. So what is the effect of having a greater number of inpatient days in your state on cost? That would be that estimate. And then we look at price, and again, it was the differential between the state level price and the overall mean across states multiplied by the incremental volume in that state, or by the actual volume in that state. And the reason we did that instead of the mean volume is we wanted the combined effect to add up. So when you do a decomposition, ideally you have two effects and you add them up and it's the total effect. And to make that work, we had to multiply, calculate the incremental price effect at the volume, the actual volume, and calculate the volume effect at the mean price. So it's just, if you added them together and did a little algebra, that's how that would work. And so those are our two effects. And so that's all the methods I'm going to give you. So we'll focus more on the fun stuff, the results. Here is overall spending per CAMOD, and then kind of the across categories. And you see there's two little pieces that are floating away. So those are the ones we're not using. So the larger one's long-term care, and the smaller one were those other services we talked about. So among the 100% of expenditure, we're losing those two parts, which is a little over 25%. And the rest, if you look at it, the blue is inpatient, the green would be outpatient, yellow is pharmacy, and red's mental health. So a lot of inpatient expenditures, a lot of pharmacy expenditures, outpatient and mental health are the next ones. And then purple, the smaller categories, purple is lab and x-ray, and then gray is home health, blue is DME, and then everything else that we're using is grouped into the pink, other acute. So that gives you an idea of where the money is spent. This gives you a feel for the variation across states. So greater variation in long-term care spending than there is in acute care spending. So long-term care is something probably we should look at too at some point. But then among acute care spending, here's the distribution across different categories. And these are dot plots. So are you familiar with what these are and what they're measuring? I see some. Okay, I see both this and this. It's a plot. Each dot would be a state, and these are ratios. So the mean is 1, and so all of the values are divided by the mean. So if you're up at say 1.5, then your expenditure is 1.5 times the mean, or 50% above the mean. And then so some states are all together and they line up. So some are lined there across 1. So if a distribution is like shorter and fatter, that means it's more concentrated near the middle. Whereas if it's elongated, there's a lot more variation, in the mean across the range. And so you can see like long-term care There's some states up there near the top, and it's more kind of spread out. Here's looks at the categories of acute care expenditures, and so there's more variation in inpatient with an outlier there. You can see outpatient, other acute, the largest distribution among mental health, and then pharmacy is fairly compact, compared to the others. So this shows overall expenditures among Medicaid beneficiaries. Pretty high in the Northeast, kind of here in the upper Midwest, and Minnesota, and New Mexico, fairly high. Lower expenditures in the South and along the West Coast. And this is the acute expenditures among CAMODS that we're looking at. So a somewhat similar story. Again, the Northeast is high, Minnesota is fairly high, lower spending again in the South, also in Washington State. This shows inpatient days per thousand. So inpatient days was a big driver in the Medicare side, and it's less here. And you'll see some states are white because we excluded them due to the high penetration of managed care. But I think the hospitalization story doesn't match entirely the expenditure story. So we have lower hospitalization rates in kind of the very, the Northeast part here, where they did have higher expenditures. The South, some bit of higher, hospitalization rates where they are lower cost overall. But then lower in Washington as they had lower expenditures too. So kind of a bit of a mixed story here, but certainly inpatient days are not driving expenditures in the Medicaid program. And part of the reason why is there's so many other types of expenditures in Medicaid, and beneficiaries will tend to use them. So this is the top 10 and the lowest 10 states with respect to spending, and we put these fairly complicated graphs together. There's a lot going on in this graph. So these are annual expenditure effects. So they are based at 0, so that you can kind of see is in the middle of all these lines is 0. If you had the average for everything, you wouldn't have a bar at all. You'd just be at 0. And now as you go to the right, these are positive expenditure effects, so you have more expensive states. And the blue lines are volume, and the red lines are price. And then the different color shades refers to inpatient, outpatient, and pharmacy. And it's from dark to light. And so we do that for volume, and we do that for price, inpatient, outpatient, and pharmacy. And then the pink at the end would be the mix of pharmaceuticals. And you can just see a couple things here by looking at the graphs. I mean, at least in the top, the most expensive and the least expensive states, a lot of it is on one side of the line or other. So most of the effects are, either positive or negative. Certainly there's some exceptions where you can see near the top that some of the states do have negative expenditure effects as well. Also, it seems like blue is driving a lot of this pattern. There's, I think, a lot more blue, or a bit more blue than red here, saying that volumes, kind of driving the story. And then you can look at some individual states, and you can kind of see some, beyond those patterns, there does seem to be some differences. Looking at kind of, you've got Alaska. The highest 10 overall is the top line, and so you can see that overall, higher cost states on average have, higher inpatient volume and higher pharmacy volume. That's the darkest and the lowest blue, and then also high inpatient price. There seems to be overall the mean big effects. As you look down, you see Alaska, DC are high in most everything, but there's different drivers here. So. In Alaska is expensive to deliver medical care in Alaska. And so inpatient price and outpatient price are very high. They also have a very large pharmacy volume in Alaska, and expensive mix of pharmaceuticals. DC is high a lot for its inpatient volume and inpatient price. So DC is a place where inpatient is really driving expenditures. That's the dark blue and then the dark red. Maine, again, another expensive place to have hospitals. A high inpatient price there with the big red bar. And then drop a couple down in New Jersey. Huge inpatient volume in New Jersey. Huge inpatient volume, in fact, probably pretty similar to DC. It doesn't quite have the price effect of DC does. In fact, hospitals are a bit less expensive in New Jersey. You see the red line going to the left. And that would offset the total costs there. So some variation across states. So pharmacy mix is kind of getting at whether they're prescribing medications that are more or less expensive. So antipsychotic versus antibiotic is an example. Yeah.
Could you explain a little more about the difference between negative expenditure effects and positive?
Yeah. So these are incremental effects compared to the mean. So if we flip back up here, this is how we calculate it. So for volume, so the I is the state and the M is the mean. And so we're looking at, are you, above or below the mean on the volume? And if you're above the mean on the volume, then that's a positive effect, and we'll multiply that by the price to kind of put a value on that volume. Let's so say your volume is 110 and the mean is 100, then you'd have a 10, and then you multiply that by the price. And if the price was 50, then that would be like a $500 effect of the volume. And so we'll do the same thing for price. And so then if you're below the mean, then that'll be a negative effect. Yeah. So if you have a bunch of positive effects, you certainly end up with an overall, positive incremental effect. Similarly for the negatives. But if you have some positive and negatives, there'll be some offset of those to come up to where you are. Yeah, so if you look at on the last line there, so we wanted the incremental effect to be additive. We wanted the volume effect and the price effect to add them to equal the overall effect. So that meant in one of the equations above, we had to put the mean, and the other one we had to put the actual. And so we just kind of chose to do it that way. And here's where we group them by region. And so here, we could try to tell a little bit more of a story. If you look at the kind of the mid-Atlantic region, I think New Jersey, New York, Pennsylvania, they're high overall, right? All the incremental effects are positive. So higher, inpatient volume is a big one. But then, outpatient's a little bit higher, pharmacy's a little bit higher. The big price effect is inpatient. So more inpatient days, we're paying more for those days. And the mix is high too. So they do tend to use more expensive medications as opposed to less expensive medications. The opposite, if you look down here at South Central, which is the South basically, a lot of almost all the expenditure effects are negative, and that's driven in large part by low rates of pharmacotherapy. So they don't do as much prescribing in the South. The other effects are also kind of smaller, but all negative, consistently negative, and kind of end up for less expenditure in South Central. So you might look at these two places and say, well, maybe they're spending too much in the Mid-Atlantic region, compared to the rest of the United States, especially since they're spending so much money on hospitals, and maybe they could focus there on reducing inpatient admissions. Down in the South Central, I might worry about access to care, right, because pharmacotherapy is so low, which suggests that, well, maybe they're missing some opportunities for better management of common chronic conditions, for example. So it's hard to know, like, without a benchmark or a gold standard, but you can kind of start to try to gain some insights by comparing the regions. The New England region is kind of interesting. So it's got expenditure effects on each side of 0, right? And if you added them all up, they end up at about the mean. Yeah, but it's interesting to see what is on each side. So on the positive side, you see pharmaceutical volume and outpatient price are the two big effects on the positive side. And on the negative side, the big effect is inpatient volume, followed by a smaller pharmacy price. So in the New England area, compared to the average, more people get pharmacotherapy, and they pay more for an outpatient visit. So I think both things that might be considered, access, improving access to care. And on the negative side, they have lower inpatient admissions, and they're paying a little bit less for their pharmaceuticals. And those could be good things, certainly. So you could tell a story about New England doing a better job at managing common chronic conditions, with increased pharmacotherapy, better payment for outpatient care to do the management. That results in reduced inpatient admissions, and maybe they're also negotiating better for prices because they're using so much pharmacy. So that's kind of a nice, I think, story to say about patterns of care in New England. So here, I don't know how well you can read this, but this is where we did a regression analysis. So we did this at the HRR level, the hospital referral region. So HRRs were made up by the Dartmouth Atlas for Healthcare Researchers. And they did a lot of the early work with the Medicare program. They now produce these atlases that show geographic variations in Medicare. And they do a lot of their analyses at this HRR level. And what they've done is they've looked at the claims data, and they've looked to see where do people go for cardiovascular and cerebrovascular care, where are they being admitted for heart attacks and strokes and things like that, arguing that if they can cluster people by those patterns, that reflects a region of hospitals where people are referred to each other. And it's linked to zip codes. And so basically it ends up being a groupings of zip codes, kind of clusterings of zip codes based on these referral patterns. And they provide this data. So you can go on their website and you can download these zip code crosswalks that'll map the zip code to this region. And then at the region level, they provide also a lot of data on supply. So their story is one about provider supply driving costs and utilization and costs. And so it's nice because then you can get all that data and use it in Medicaid.
How often do they update those?
I think annually. So that's what we did. So we pulled that data, and if you look on the top set of things, they're called market supply, and they're kind of the traditional Medicare variation predictors. So acute care beds, per 1,000 population, the primary care physicians, and the specialist care physicians per 1,000. So both kind of hospital bed supply, primary care supply, and specialist supply variables there. And then below that are some of the Medicaid characteristics that we calculated at the state level. We're looking at, these are price and volume, so inpatient admissions, price per inpatient day, outpatient visits on average, price per visits, and then the pharmacy variables. And then we looked at the effect on hospital admissions overall as something maybe you'd want to reduce, and then disease-specific admissions, and these would be the idea of those ambulatory care-sensitive conditions we talked about, diabetes, COPD, CHF, and asthma being the ones we looked at. And then we looked at the effect, and we calculated this over a 2 standard deviation change. And so overall, and within disease-specific, a greater number of hospital beds seem to result in or be associated with higher hospital admissions. So this is something the Medicare folks have seen for a while. So the more beds there are, the more people that get admitted to the hospital. And then under primary care, we see kind of the opposite effect, more primary care physicians, fewer hospital admissions. Although it's not significant overall, it's significant for 3 of the 4 ambulatory care sensitive conditions. And then specialists per 1,000 populations, increased rates of admissions, both overall and for these other conditions. So that's very consistent with the Medicare story, that places with more hospital beds and more specialists, you get more admissions to the hospital. On the Medicaid side, and looking at those predictors, some of the interesting predictors are, the number of outpatient visits and the price per visit. So you can see kind of overall, those have pretty strong negative effects, but there's some inconsistency when you look at, the ambulatory care sensitive conditions. Down below, we control for the CDPS score, the severity index, and which we would expect to be related, and the percent in HMO. And so among those, when there's a lot of HMO in the state, we see some reduced admissions. So not like a super strong case in that it's not consistent across the categories, but there does seem to be some evidence that having a greater number of outpatient visits and paying more per visit could be related to reduced admissions. And so that's kind of our story on, is more better. So, we found kind of in a few different predictors, supply of PCPs, the number of outpatient visits, and the price per visit were all related to reduced admissions. So this idea that you could provide more robust primary care, could offset some inpatient admissions. So that's where we looked at, variations in Medicaid. So our research questions were kind of, what's driving it? So it seems to be a lot of, again, a big story about volume, although there is some price effects as well. And is more better? Maybe a little bit of evidence for that. The middle question there was it related to Medicare? Here are our dot plots again. So compared to Medicare and Medicaid, it has a little bit more variation in spending across states. Medicare seems more compact here. Here's Medicare spending per beneficiary. So this is a very different map, right? So here the South seems more expensive. Where Medicaid, it seemed to be less expensive. California is very expensive in Medicare. It was not a really high state. Minnesota is not expensive in Medicare, and that was a high state for Medicaid. So already we can kind of see some differences. This is a scatter plot, so not much of an association here between Medicare and Medicaid. And then we decided to say, well, what about separating it by inpatient versus outpatient? And so here is inpatient, so a little bit more of a relationship. The line is a regression line between the two. If it wasn't for kind of maybe Hawaii and a couple other states, you might see that shifting up a little bit and might kind of track these a little bit better. But there is a statistically significant relationship here. So what we're trying to look at is, in a given state, whatever variation is driving, one population kind of similar. So you would expect to see that maybe if this was really a supply side story. So here there's really no relationship. So then we try to look within states. So the idea that, well, maybe there's some state effects in the Medicaid program. And this looked more promising. So these are the hospital referral regions in four of the largest states, New York, Illinois, Texas, and Florida. And again, these are plots of Medicare versus Medicaid scatter plots. So we labeled them by the area. And here there does maybe seem to be a better linear relationship. So New York, the expensive places, are the Bronx and Manhattan. And then kind of upstate New York is the less expensive places down in the left, bottom left corner. And that seems to be the same. Medicare and Medicaid track pretty well. Illinois, kind of same thing. You've got kind of Chicago up in the top, and kind of down the bottom would be kind of Springfield and the more rural downstate areas. Texas, the McAllen story, Waco McAllen. Story. Atul Gawande compared them in the New Yorker, and as high and low Medicare, they're also high and low Medicaid. And again, we seem to see kind of a fairly consistent relationship across Texas. And then in Florida, again, Miami being the most expensive, but even without Miami, seemed to be a bit of a pretty good, consistent relationship between Medicare and Medicaid. So we thought we figured it out. So like if you look at the states compare state level, they're not related. But if you look within the state, Medicare and Medicaid do seem to be related. And then we look at California, and kind of it doesn't really hold up there as well. So this again looks just more like a scatter plot cloud. Los Angeles, expensive in Medicare, about average on Medicaid. San Francisco, high on Medicaid, about average on Medicare, and so on. So not really the story we were hoping to have. Why would you expect them to be connected? Yeah, so a lot of the story with Medicare variations is that they're regional, and they're driven often by the supply of hospitals and specialists. So if you go to a place like Boston that has a lot of hospitals, academic medical centers, a lot of specialists, and you live in Boston, you're more likely to get intensive care than if you're the same person and you live in, say, New Haven, Connecticut, where there is, one hospital and so on. Some of that might be transmitted by culture. In Minnesota, basically everyone went to the same medical school. Maybe they all practice more conservatively than if you go, again, Boston or some other place where people are from different kind of medical cultures. But there seems to be places where you get intensive care and places where you don't. And if it's really a story about place, well, then we'd expect the same thing to happen in the Medicaid program, right, if you're in an expensive place and not. And we'd expect this to happen more in hospitals, because people tend to share hospitals more than they do in the outpatient setting. And that's kind of generally what we're finding here. Certainly among these big states, it kind of seems to be related. But then among California, it doesn't. And so one thought is maybe when your areas are large enough, maybe you have more segmentation where you have kind of Medicare and Medicaid individuals going to different providers, which on the outpatient side could certainly be true. If a lot of Medicaid is delivered in community health centers where it's kind of Medicaid or uninsured, where Medicare, they have a lot more freedom to go to different provider groups and so on. And it might even be that, in the hospitals in California, they could even be segregated there as well. Maybe there's kind of certain hospitals that Medicaid patients go to, more public hospitals. Yeah, I mean, we limited it to, the fee-for-service, but that could have led to some selection into the sample, definitely. Here's looking within Medicare and Medicaid, across all of them, and normalized as deviations from state means. So this is a plot at the hospital referral region level, pulling out the state effects. And this seems to track fairly well. So I think with the exception of some places like, California, which might be one of these little dots that are way off the line, that a lot of states within them do match pretty well, the Medicare and the Medicaid. So kind of from these studies, we found wide variation in Medicaid spending per beneficiaries. New York spends about twice as much as California, for example. We found significant regional variations. But kind of inpatient utilization is much less of a story here. And there's a lot of other spending categories that are important in Medicaid, which do have large amounts of variation in it. Volume is, kind of more important than price. There is some price effects, but volume, counts for 2/3 of the variation in the Medicaid level. And at the state level, Medicare and Medicaid aren't related. So very kind of a weak relationship in inpatient admissions, no relationship in outpatient, and so not a lot on the state level. But within states, inpatient admissions at least are very strongly related, with the notable exception of California. So it seemed to be within states, they are indeed sharing the same hospitals and some of the same things that are driving variation in Medicare expenditures also, drive Medicaid. But they don't seem to be sharing the same outpatient providers. And also the state effects seem pretty important. So when they're included, that really washes out any relationships you would see. And so we think those are arguments for large state effects that probably need to be investigated in more detail. And then some suggestion that kind of more might be better in Medicaid, certainly at least on the outpatient side. So I hope this gives you an idea of kind of how you would wrestle with the whole data set, how to kind of cut it into manageable groups, kind of investigate an issue. Most of the time, you're actually focusing on something a little bit more smaller, a little bit more focused study, which makes things a little bit easier. But when you kind of go for larger groups, you got to then kind of have these trade-offs of messiness and heterogeneity to get larger numbers versus kind of narrowing it down to get to something more specific where you maybe lose some generalizability.